Cirrhosis is a chronic progressive disease characterized by extensive degeneration and destruction of the liver cells. This short wrap-up video will focus on the complications and some of the interventions geared towards those complications. There are several causes of cirrhosis. We can have alcohol cirrhosis, which is associated with alcohol abuse, hepatic cirrhosis, which is a complication of hepatitis. Those are the two most common types of cirrhosis. You can have non-alcoholic fatty liver disease, and that's commonly found in patients who have a history of diabetes or metabolic syndrome. Biliary cirrhosis from patients with chronic biliary obstructions, and cardiac cirrhosis. Usually it happens with people who have severe, long-standing right-sided heart failure. Patients with cirrhosis can have lots of signs and symptoms, and it really does affect them systemically. So patients can have some or all of these manifestations. So you can see neurologically, very common will be the hepatic encephalopathy. GI, a lot of symptoms GI-wise. Ones we're really concerned about is going to be the esophageal varices, hemorrhage, anorexia, change in bowel patterns. There's reproductive problems as well, depending on the patient's age. That might be an issue for them. Skin-wise, jaundice is very common. Some of these other ones are not as common, but jaundice will probably be your most common sign and symptom you'll see. Hematologically, anemia is a very chronic problem that we see. There's also coagulation disorders, so we worry about bleeding and blood loss. Electrolytes and low albumin levels are also going to be another concern of ours, so we're going to be very worried about those low potassium and those low sodium levels. The low albumin levels are also going to play in part to malnutrition, as well as some of the fluid retention that occurs, which leads into some of those cardiovascular problems such as the fluid retention, the peripheral edema, and the ascites. So portal hypertension is the persistent increase in blood pressure in the portal venous system, and this leads to increased venous pressure in that system, which can lead to these large collateral veins, which you can kind of see on this image here, as well as hemorrhoids in the lower GI system. We're also having problems with ascites and esophageal varices, which will come up here next. So esophageal and gastric varices are large veins in the esophagus or the gastric system. Esophageal varices are the most life-threatening complication of liver cirrhosis. So, we have to think about if there's bleeding in the upper airway, not only do we have profound blood loss, because like we said, these are large veins, so we're having blood loss very rapidly from large veins, but we're also in the upper airway, which can cause problems, not only aspiration, but the person can suffocate. So if we have someone with these bleeding varices, our number one priority is airway. So we have to worry about their airway, because if we lose the airway, we're not going to be able to do anything else for this patient. So we're worried about controlling the airway, possibly inserting an artificial airway, which can be difficult if there's profound blood loss. So that's just something to remember, that intubation may be necessary and difficult. We want to get 2 IVs in, and then we're also worried about IV fluid and blood getting in. So those are kind of our main initial emergent things that we're worried about. This would be a patient who may be needing to go emergently to the operating room, where they're going to do some banding or cauterizing of these esophageal varices or gastric varices in order to stop the bleeding. Ascites, another complication related to that portal hypertension, is the accumulation of fluid in the peritoneal and abdominal cavity. So this is a very common complication. You're going to see abdominal distension, weight gain, So you may see this very, very thin patient, but then they have this very huge abdomen. And as it gets more full with fluid, it gets very, very firm. So when you're palpating the abdomen, it is very firm. To treat this, typically it's going to be diuretics, low sodium diet, and in some cases they may have a paracentesis. And we talked about paracentesis before. Paracentesis initially might be done to do some diagnostic workups, but really it is more of a palliative intervention. It's really to provide relief. So it's removing that fluid to help them feel more comfortable. Long-term treatment would be placing a shunt, which would reroute some of that fluid from the abdomen to the vena cava to promote it into the venous circulation to help decrease the fluid in the peritoneal cavity. So you can see by this image here that this is all fluid. So this is all fluid in here. So this is all fluid. So what that's doing is it's compressing the organs. So the person feels very uncomfortable. Not only is their skin pulled very taut, and they have extra weight here, which is uncomfortable on their back, but their organs are being compressed. So this is a lot of times what can lead into that anorexia, that nausea, that vomiting. They're not hungry. They have no room for any food. It becomes hard for them to breathe as it compresses against the abdomen. So if we do remove fluid, so if we're thinking about taking off that fluid with that paracentesis, again, the patient should void before a paracentesis, but now we also have to worry about not only watching for signs and symptoms of bleeding at the site here, because we're worried about some of their coagulation abilities, we have to worry about the amount of fluid that is removed, because if we take off too much fluid, it can decrease our blood pressure. It can also impact our electrolytes. So we're worried about really that potassium mostly. So really paying attention to any signs and symptoms of electrolyte imbalance and hypovolemic shock. In addition to the fluid in the abdomen, we have increased risk for peripheral edema, and this can go from the toes all the way up to the sacral area. So peripheral edema is treated the same here as it would be in any other case, such as heart failure would be low sodium diet, fluid restriction, diuretics. And so we need to also keep in mind anytime we are giving lots of diuretics to our patients to be looking at their electrolytes, specifically looking closely at our potassium and magnesium. Hepatic encephalopathy is another complication, and this results from the neurotoxic effects of increased ammonia in the bloodstream. And so remember, when our liver is functioning normally, part of its job is to convert ammonia to urea and send it out through the kidneys. And it can't do that in liver failure, so ammonia builds up. Also, if someone is having any internal bleeding, so if these esophageal or gastric varices or bleeding ulcers are bleeding very slowly, there is an increased buildup in amino acids. And again, remember, they cannot convert that to urea. So they have this buildup of ammonia in their bloodstream, which then leads to them having some of these neurological and mental status changes. So you'll see in patients impaired levels of consciousness. They may become very confused and combative for no reason, and then really end up being very somnolent and comatose. You can also see asterixis, which is these flapping tremors. So for no reason, you'll see the hand flapping back and forth, and that's a very good sign and symptom of hepatic encephalopathy. They may also have a musty, sweet odor to their breath. So treatment for hepatic encephalopathy is lactulose. And what lactulose does is it traps the ammonia in the gut, and then you release it through your stools. So lactulose causes severe diarrhea. And you think, well, how do I give this to a patient? Well, it's given orally, so the patient has to drink it. If they are too comatose, let's say, other options would be to put an NG tube down and administer the medication through the NG tube. The other way is through retention enema, so it can be absorbed rectally as well. So those are your two ways to give lactulose. And then as the person expels the ammonia through the stool, you will see their symptoms resolve. So lactulose can be a common treatment for patients with cirrhosis to help prevent hepatic encephalopathy. But you will see a lot of patients being non-compliant with this because the main side effect is diarrhea. So patients won't take it because either they're still working or they're going out or they just don't want to deal with the diarrhea. And then they end up in the hospital with this hepatic encephalopathy. So compliance with this at home, if your patient is prescribed this, is extremely important. There are additional resources about cirrhosis that can be found on your course website. Thank you.